everyone. Three people out there, perhaps. I don't know. I'm not keeping too much track of that. All right. Well, as is usual, I am driving home from work, hence the name of the podcast. Although I hope one day that I'll be able to make this a proper podcast and get some time to do it at home. And maybe I'll have to change the name. So if anybody's got a good name for a proper podcast, I would be all ears. But anyways, today I'm going to talk about brief psychotic disorder and its differential. And this is inspired by a case I had in a paper that I read on a case series. The paper is, I believe it's Gallenker. That's like Galynker. I believe that year was 1996 et al. In the Journal of Clinical Psychiatry. And it was a case series on some patients that had what appeared to be panic attack triggered psychotic episodes. So these were psychotic episodes that were very time limited, very brief, and seemed to be always preceded by a panic attack. And I believe the syndrome was named panic associated psychosis. And first of all, this appears to be fairly rare. At least in my career, I have only possibly come across this one time so far, and I'll talk about that. But so much as it is a real thing, the interesting part was that the patients all got better without antipsychotics and just with treatments for panic disorder. And so there seems to be a clear mechanism of whatever sort of catecholamine surge, sympathetic nervous system overdrive that you go in a panic episode seem to trigger their brains to go into a psychotic episode. And so by preventing the panic attacks, you prevented the psychotic episodes and could avoid an antipsychotic. So that is an interesting condition. Again, it's not something I've come across too often, but something to keep in mind if you ever have patients with very brief psychotic episodes. So I had a patient in the inpatient setting where they were admitted for psychosis, and the history was very clear that this was a genuine psychotic episode. Internally stimulated, seemed to be interacting with things that weren't there, talking to things that weren't there, and endorsed hearing voices, and it seemed to have kind of bizarre beliefs during this episode, be briefly delusional. It was triggered by a panic attack. And by the time this person landed in the psychiatric unit, their symptoms were pretty much all the way gone. I mean, maybe there was a little bit of hearing voices or a little bit of paranoia or something like that left. So I didn't really know what to make of it so much, since they had, appeared to be dramatically better without any treatment at that point. I went ahead and put them on an antipsychotic medication and observed them for a couple of days, and they were fine. That their symptoms appeared to completely abate within the first 24 hours on the unit. So no more hallucinations of any kind, no more paranoia. They were calm. They had pretty normal affect. So basically their mental status exam was totally normal. And this was a very low dose antipsychotic, because again, by the time they arrived, they were already dramatically better. So, I just started them on a very low dose. So they had supportive families. So we discharged them back home. I did send them out with that low dose antipsychotic. Of course, we set them up with outpatient care and figured their outpatient psychiatrist would have to have a conversation about what to do with that. There were no substances on board or anything like that could explain this. Just that they had a panic attack. They were really anxious, and it triggered this paranoia and psychosis. So, anyways, the patient was then readmitted with the same thing a few weeks later, and again, they had a panic attack. They had a psychotic episode, full blown psychotic episode. They get admitted, and again, right after admission, they're basically back to normal again. Maybe there was a twinge of something, a little bit of anxiety, a little bit of paranoia left. They had said that they had been taking the antipsychotics since their last hospitalization just a few weeks prior. They were, pretty reliable historian in that regard. So I didn't have any doubts that this was a medication not adherence issue. Yeah, they just said something triggered anxiety. They had a panic attack, and then all this weird stuff happened. And then they had some pretty decent insight. They couldn't tell you exactly what had happened, but they knew that they were behaving abnormally and weird stuff was happening to them. And collateral from family was indicating again this was clearly a psychotic episode. But it was very brief. I mean, we're talking 24 hours or less. In any case, we ramped up their antipsychotic. We gave them an anxiety medication. And in this case, it was not an SSRI medication. We were just using hydroxyzine to treat the anxiety in the short term. Because, again, after just a few days of observation on the unit with a higher dose of the antipsychotic and some hydroxyzine, they felt totally fine. Not really any anxiety, no psychotic symptoms, no mood symptoms. So again, this was kind of hard to know what to do with. Do you keep this person on, this higher dose now, an antipsychotic long term? Is this panic associated psychosis? Should they, be on an SSRI in that case? I don't know, So I don't have a good happy ending to the story. I haven't seen them again since, but I did want to sort of talk about the differential for this kind of a situation. So I already mentioned one as being this panic associated psychosis. The DSM doesn't have such a thing. It has brief psychotic disorder, which is psychosis that is at least a day long, but less than a month long. Now, what is that biologically speaking? Brief psychotic disorder also appears to be fairly rare just anecdotally. It's not something I've come across too often. The other possibilities could be a trauma-related dissociative attack. So maybe it wasn't true psychosis, but it looked like psychosis. It was just a really severe dissociative episode in the context of something like PTSD. Could it have been just a really brief psychotic episode in the setting of a mood disorder like bipolar disorder or major depressive disorder with psychotic features, and it was just very brief? I mean, that would be quite unusual, but from a sort of etiological standpoint, I suppose it's possible. The other option could be that they have a primary psychotic disorder like schizophrenia, schizoaffective disorder, some sort of schizophrenia spectrum disorder, but their baseline level of symptoms, the chronic level of psychosis is just very subtle, very low level, to where they can function pretty normally most of the time. Maybe they don't have great insight into their baseline level of symptoms, and so they don't really report it. But then when stress comes along, it gets unleashed and you get this exacerbation, this acute exacerbation of their schizophrenia or whatever they're, with this primary psychotic disorder, and it just flares up. And then the stress goes away and it kind of returns to this very low level baseline. So that was my other thought. So if that was the case, then you would want to treat with a long-term antipsychotic, most likely. If it's some sort of a mood disorder, then, I'd want to put them on a mood stabilizer, or probably the plus that antipsychotic. So the actual diagnosis here matters a lot. But when the episode is so brief like this, it's really hard to know what's going on until, I guess, they're just going to have more of these episodes, and maybe the pattern becomes more clear. Or if it's a primary psychotic disorder, maybe the baseline symptoms worsen, especially if it's more of a schizophrenia type thing. I would expect some degree of worsening over time. Or if it's a mood disorder thing, then maybe that's going to become more prominent. Or if it really is always just a panic attack preceding and it goes away, then maybe I would try just putting them on a serotonin reuptake inhibitor or maybe a benzodiazepine and seeing if that prevents these psychotic episodes. So that's pretty much all I wanted to talk about. It was just an interesting case and some interesting literature on similar cases, these panic-associated psychosis. I'd certainly be curious if anybody out there has had something similar, and if you were able to figure it out and what's good for it. So in any case, take care.